My name is Michelle Brunson, and I'm the Health IT Advisor with Telligen for the Small, Underserved, and Rural Support Quality Payment Program Resource Center here at Telligen. And presenting with me today, we have not only my colleague here at Telligen from the QIN-QIO, Sandy Swallow, but we also have two guest speakers, Caitlin Nolte and David Appy from the Great Plains QIN, and they are not only here to present with us, but they're also so kind to share their MIPS calculator and show how that MIPS calculator can be used for you as you navigate through the MIPS program. And so we are so thankful to have them here today. And Sandy and Caitlin, they work with groups of 16 or more clinicians in larger health system ACOs in their work with the QIN-QIO. So thank you for joining us. And before we get started, we do want to let you know we value your opinion. So in the next day or two, we will send you a short questionnaire. If you wouldn't mind completing that, that gives us great valuable feedback that we will use in shaping our future webinars. So we really appreciate if you could complete that and help us out with that. And then also the recording and slides from today's demonstration will be available on the TelligenQPP.com website under the Resources tab, as well as the Telligen QIN-QIO and also in the Great Plains QIN-QIO. So we'll show that later, but I just want to let you know that. And today we'll explore, today we're going to explore the simple tool of this calculator and project how this calculates your MIPS final score. And we're going to review a couple different scenarios of different practice sizes, both something typical for the work that I do with the small, underserved, and rural, as well as for what Sandy sees in her work with the greater health systems. And then we will estimate how the financial impact of MIPS can be, the impact on your practice depending on what your score is. And finally, we're going to describe assistance and resources available to you to help you in your journey.
Well, I want to just welcome all you attendees, and also I want to welcome our guest speakers. Caitlin Nolte is with the Kansas Foundation for Medical Care. This is a healthcare consulting company based in Topeka, Kansas. And as a project manager for KFMC, Caitlin has provided coaching and mentoring support to providers and clinical staff in preparing for participation in the CMS Quality Payment Program. She assists them with simultaneously delivering excellent quality of care at lower total cost while improving the health of their population of patients. She received her bachelor's degree in applied behavioral science with concentration in community health and development from the University of Kansas, or KU. In her role with KFMC, Caitlin continuously collaborates and coordinates activities with CMS, National Coordinating Centers, and other contractors working on quality payment program initiatives. David Appy obtained a Bachelor's of Engineering with majors in Computer Engineering and Mathematics with Vanderbilt University. His primary role at Kansas Foundation for Medical Care is to create tools and reports that promote their work with CMS. And we greatly appreciate these folks willing to share their expertise on the MIPS calculator with us today. I think Michelle has passed the ball to David, and David, we'll turn it over to you, or Caitlin, whichever one's going to kick off first.
Sure. Hi, this is Caitlin Nolte. Thank you for having us join you on this webinar. We are very excited to showcase this tool, and I'm actually going to work with David. He is getting the tool up on his screen. We're just going to walk through the tool's basic functionality and talk about some key triggers that folks that are utilizing this tool will want to be aware of. And then, as Sandy mentioned, we are going to walk through a couple of scenarios, and then we'll have time to answer the questions. And David, I do see your screen. Is your line unmuted?
For me?
I can.
Okay, finally it let me unmute.
All right, so David has up the cover sheet of the tool. Something we want to definitely make very clear is that this tool was created to help facilitate discussion in practices and health systems and really help folks strategic plan for the 2017 transitional year in the MIPS program. Something we definitely would like to notice that the calculations in this tool are not a guarantee of payment. So go ahead, David, and advance to the guide page, please. You'll notice that this user guide tab is supplemental to the tool. There are certain fields that are noted throughout the tool that hold additional information, and you can actually hover over the red corner and it will show you that supplemental content to go along with the data that you're entering, or it may just simply be an explanation as to why you are entering that data. The orange cells identify where you would input that data. And then you can go down the list and review the rest of that, but we'll go ahead and show you the main MIPS tab. And David, I will go ahead and let you kind of give just the overview of this, and then if you want to walk through a couple of triggers on your screen, I think that would be helpful.
Well, this is pre-populated with a scenario that I believe Michelle or Sandy was going to describe, but you essentially have our inputting. To begin with, the first thing that you have to know is how many MIPS eligible clinicians are you estimating this MIPS calculation based upon. That is inputted in the first cell, and then you'll enter in your total charges for all those clinicians. If you have more than 15, if it's 16 or more, you will want to put in your total case volume. You can do it for the less, but it really won't affect anything. The addition of that is due to groups of 16 or more automatically having in a hospital readmission rate measure calculated within their quality measure set. The other two items calculate our option boxes to subset for your low volume thresholds and your reweighting of the vaccine care, for the improvement activities of providing double points on that. Sandy, are you wanting to provide your scenario?
Sure. This is Michelle, and I can start off here first, David. So we will use a hypothetical scenario. Again, I work with the small, underserved, and rural clinicians in the states of Iowa, Nebraska, North, and South Dakota. And so for our first hypothetical scenario, we'll say I have an ENT practice of Iowa. And my practice, I have 3 eligible clinicians, 1 physician, 1 physician assistant, and 1 ARNP. They are going to do group reporting, and they have an EHR. It is all scripts, and their EHR is 2014 certified. They use a qualified clinical data registry for submitting their quality data, and that's Reg ENT for otolaryngologists. And for the advancing care information and improvement activities, they're going to simply use the CMS portal to attest. So they won't have their QCDR do that. They will do that themselves. And finally, they are using a 90-day reporting period for their 2017 performance.
Okay, so as we've already entered in our 3 clinicians and their total amount, which if you can use formulas within these, since it's averaging and everything else, we're just doing estimations. We could do to make sure if we wanted to say that they were each having about 29,000, then they hit their low volume threshold and there won't be calculations for the 2019 adjusted year, and that's seen down at the bottom in the reimbursement area. But right now we're just wanting to show that how it would be if they were not in the low volume threshold. Below that, we start entering in their measures because we want to see where they can improve, what best measures they should be focusing on, and things of that nature. Now, with a non-web-based submitting and the non-APM, they'll be scored based upon 6 measures since they are under the 16 clinicians. So we want to have at least 6 measures. Here we see that they have 7. We've gone through, added in the 130, documentation, everything else.
Oh,
they had an 88.71%, which
David?
Yes.
I'm so sorry to interrupt you. Would you mind switching to the quality tab there?
Oh, sorry, I forgot to.
No, that's okay. No, that's okay.
Sorry about that. Thank you. You will see that they have reported 7 measures. The top 6, the lowest measures, the 7th one in the ranking, the one that won't be counted towards the performance score, is grayed out. This just identifies to let you know, okay, this one's not, the estimated points aren't going towards your actual performance score. But it could, if this was a high priority or outcome measure, their bonus points could go towards your bonus points aspect. So if instead of 61, you can see to reach the 10 points would be 100%. If we went to the 100%, then it would change the lowest ones to being the 332. And then your high priority bonus points would still stay the same because it is a high priority and it doesn't care if it's being reported towards your performance score. Then, as we continue on, we're adding in more info. We want to go over to their vaccine care, their EHR. At the top, you're selecting 2014. That's what it certified your technology for. We pre-populated this to allow for quicker talking, hopefully. This first section is the required measures. Technically, these 3 that you see just require that, the way it states is 1 in the numerator. That, if there's 1 in the numerator, there's at least 1 in the denominator. So you've at least been reporting on 1. So we've added them in to their rates. The base score, you have to have that in order to even start getting points for that performance category. Once it's certified that you've started having those, you can get the base score of 50. These rates start going towards your performance additional score. So these performance rates, if it was just them, they would count towards an additional amount of points, but we continue on, we see that they've done everything else. They have optional measures on any of the...
David?
Yes.
David, this is Dr. Tom Stoltz from Yankton. As a chiropractor, that e-prescribing is not a requirement?
Correct. You would be reporting in as a null, which is done by just pressing in a 0. Your score, then the rate would not go towards any additional performance on score points, but you will receive the base adjustment base score requirements.
Thank you.
That is one scenario that allows a little exemption that's in there. If you highlight over the cell, you'll see if less than 100 permissible prescriptions written or no office visits occur during the EHR reporting period, please enter a 0. That indicates that you would be reporting a null value to CMS. And if we go back to the MIPS we'll see that you got your base score of 50, along with 41 additional performance score points that is out of another 90. So that's about half of the points available. Let's see. No bonuses are being done, so that doesn't count towards anything. Now, with the 2014, you are getting, this is, base score is there, it's just, you go, the additional performances are going to that additional point numbers. Your improvement activities, we see that up at the top that I've highlighted a one I-weighted measure which was on down here. I can't remember which one it is.
It was engagement of new Medicaid patients. Yep. There you go.
I searched for Medicaid, and it would bring us down there, and you would click yes. This one is not a one that should be used towards your Veteran Care Information bonus points. That is you seen by going is, are you reporting improvement activities using CERT? If you do any of these that are using CERT, you would check it. But like if I check this now, it would show at this top that unmatched yes and use CERT checkboxes, since I'm not saying I'm engaged in that. So we don't check it. Now, going back to the MIPS tab, you get 1 point. But since they are a rule or small practice, their improvement activities points, the highway are doubled worth than what they would be if you weren't. So it becomes, you end up receiving the full impact, everything that you capped it out since you did the one that they're ruled. Now, if they weren't, it would have to amount and they would not be capped out. We're saying they're using the standard calculation, so the 81.93 is their final score, and that is what is used for all estimations. Now, we'll go on to the exit report. You'll see that as we go through, reporting 7 measures, scoring based on 6, receiving 5 bonus points, it's letting you know that you've used the same submission method for all, because CMS will only take the measures from the same type. You couldn't do some EHR, some registry, some this and that. Except for whenever you have the all calls readmission rating to hospital. That will be claims-based, but that's not something you'll be reporting. That's something they'll calculate outside of everything. Let you know you meet requirements of the one outcome or high priority measure. All of them are available with submission methods, except it does highlight that you're submitting 4 topped-out measures. For the 2017 year, doesn't really matter. The score processing is the same for topped-out measures as they are for everything else, but in future years, they may be adjusting that. They have not closed the book on the scenario. There may be weighted scoring and other calculations done to almost penalize for doing only topped-out measures. You look at the Veteran Care, it lets you know that you're using 2014. All measures have been met. There's optional measures, you're receiving 0 bonus, and you have met Medicare EHR meaningful use. This is not the same as Medicaid EHR meaningful use, but it is according to the final rule for this Medicare. Improvement activities gives you a synopsis of that and your full scores. Now, down at the bottom, you'll see that your scaled adjustment factors for everything and your range of reimbursement. values. That's because nothing is guaranteed. There is a section of the base score that it states that there is budget neutrality. So until all things are said and done, we will not know how much in truth people will be getting. For the positive adjustments, the negatives are set, but they can reduce the amount of percent on your base score down to all the way to 0, up to 3 times as much. So in 2017, that makes the scale from 0 to 12. But the applicable percent in the final rule is 4%, so that's what everything is believed to be where the budget neutrality will hit. So for this person, they had a scale from 0 to 16.28. If you look over at the MIPS tab, I'm showing their base score adjustment is at 4 because they've reached over the exceptional threshold and into the additional. That 4 scaled at 3 times comes 12 plus the additional 4.28, that is up to 10%. But that also can be reduced if too many people get into the exceptional, because there's just a finite certain amount of money that has been allocated within macro to be dished out for the exceptional factor. And you can go through and see the split up, the totaling, the split up between clinicians over 4 years. You took out one of those, it'd be over 3. And of course, these are just estimates because they have not been told to us yet. That is something that will come out the year before, or pretty much the time of reporting period. We can go on, I guess, to the next scenario.
David, can we go back to that scenario for just a minute before we move on?
Mm-hmm.
So for people, when they're looking at this, most organizations, these smaller organizations, when they're looking at this and they're looking at their final score and it's showing that their final score is 81.93, then what they can do just to look forward to 2019, just for one year scenario, they can think that most likely what you're telling them is they're going to get a 4.28% bonus or percentage increase in their reimbursement. Is that correct?
If they reach this final score, if this ends up being the approximation and scaling that we've used ends up being what they come out to, then these, for the 2019 adjustment period they're reporting in 2017, those we know the neutral and exceptional minimum already, so that lets us know that they have already passed the base. They are going to for sure not have any negative impact, and they're going to have the max amount of percentage that is going to be set out for anybody, along with they get linearly scaled the 4.28% of the money. Like, it's going to be 4.28% or less, but they get into the additional factor.
That exceptional bonus money, correct?
Yes.
Okay. I just wanted to make sure that I understood that correctly, because I know that gets confusing for us, all of us. And I know that this is just an estimate, because again, it's budget neutral, so we won't know for sure. But what this is just doing is helping them to maybe strategize a little bit, and also realize if they don't report to the MIPS and don't meet the MIPS, that negative adjustment, if it was somebody that wasn't reporting all this, what the negative adjustment could happen to them too. So, okay, ready to move on to scenario number 2, which is...
one quick thing while we're talking about that.
Before we do that, could we ask a question?
Okay.
David, are you okay with questions being asked now?
Oh, yes.
Okay.
That's how I'm usually writing it, so.
Okay, very good. Wanted to make sure.
So we have a question in regards to the on the screen that you're on right now. Towards the top, you're talking about the individual categories themselves and calculating their potential points that they have. Mm-hmm. When you look at that, you can see that you've taken, for example, the advancing care information. Their base score is 50, their performance score is 44, but their total points is at 94. It's 22.75, I think, or something like that. So that's taken out of that 25% possible for that category. But it doesn't look like you took the quality points out of the 60% possible for that category. Can you explain why you didn't do that?
Yes, that's where it gets a little confusing. With the quality points, that 33.18 is out of 60. So then you're multiplying that score then by another 60%. So in truth, it comes out to being the 38.18. Since it's just a cancellation of the values. If we bump this up to above 16, where it then becomes out of 70, your points will change.
Can you explain why you multiplied it by an additional 60%?
The way the points themselves within the quality measure, each one of these measures are worth 10 points. If you want to report it on one, like for each measure, there are 10 points. We got 4.69 out of 10, 7 out of 10, 3 out of 10, 3.9, 2 out of 10.
How are you only getting 4 points for 88% out of 100?
Yes.
How are you only getting 4 points for that?
I can explain that. This is so. You'll notice on the right it says that it's topped out.
Yeah.
Each of these measures are calculated based on historical data that was submitted depending on the submission method. And so there is actually the 2017 MIPS benchmark that is out there on the CMS website under Resources, and it's listed here under the tab Quality Benchmark. And so because that is a topped-out measure, meaning that people have been submitting it for a long time and they've done very well, they're used to it, you can score, as you can see here, even 99.99% and score 7 points. It's not until you reach the 10th decile that you get, or 100% that you get the 10th decile.
Okay.
And so
our measures could be different too then.
Every measure that you choose is going to have different percentage points, and that's what's so great about this tool. That, David, if you want to show maybe in Sandy's example how you enter in the percentage and then it calculates the estimated points, because it knows that we are using a registry or QCDR, in this case a QCDR. So it's looking at that submission method from the quality benchmark, and it's looking at the percentage, and then it calculates the estimated points on that for that one specific measure. But you will choose maybe 6 entirely different measures, and so it knows based on what method you choose and what your percentage is, what your estimated points, and it's pulling it from that quality benchmark tab. So thank you, David. You're showing this here now. Go ahead and talk to what you're doing there.
I'm just showing what these different measures, like this topped-out measure, it's highlighting this one red, the submission method, because it's not the same as the other ones. So it's like, hey, wait a second, you can only do one submission method. But it's useful to see playing around with your numbers. So since this one technically isn't a good one, but let's go back up to the one, or the 358. It's also a top-out measure. It does be claims isn't useful because it's not a submission type that's available for using. Neither is the HR, so that was not 130, I know was. we can go through and check, okay, if we got, this is 432 out of 487. If we got up to 450 out of 487, it still don't help that much, but it does start showing you, like this is the strategic planning. Should you be reporting by EHR? Should you be reporting by registry? On those types of scenarios, how much of a difference will it make for the measures that you'd like to use? And
okay, so then you get your total. You total all the points that you get here, which is how you got the 33.18.
Yes. And then that's out of 60, so it would be calculator on 35.11 divided by 60 is that much.
Right.
Now, for 100 points, for a 60%, that would be times 0.6. That's 35.11. Out of that, then you multiply times 100 to take it out of your percentage, out of the percent range, and then plus the 6.
Okay, I guess I'm just not following why you're multiplying it again by 60.
Because these are two different values. This is the weight of the whole category.
Okay.
Versus the weight of the actual value.
Some organizations will be able to get more points depending on, like, if it's a large organization that gets the readmission measure, then there's 70 points. They can get up to 70 points. So that's why they have to take it by the number of points that your 10 or your individual, depending on how you're reporting, can get that. But this calculator will do all those calculations for you.
Yeah, you don't have to manually do any of this, but this is great, David, to show how it works behind the scenes, and that's the beauty of having the person who helped build this tool helping us today with it. It does it for you, and that's a great thing. It's all linked then, correct, David?
Yes.
That's great. That's a wonderful question, too.
Okay, shall we move on to scenario number 2, which is my scenario. And again, as Michelle said, I work with the QIOs, and I work with the larger organizations, and this is a very typical scenario for me. I'm calling this, and again, this is all hypothetical, I'm calling it Greater Medical Health System, and they have, it's one independent organization with one PIN that's associated with one critical access hospital and 4 clinic locations. They're not associated at all with a Medicare Shared Savings Program plan 1, 2, or 3, track 1, 2, or 3. But they have 18 MIPS eligible clinicians. They have 2 emergency room physicians, 1 CRNA, 1 radiologist, 2 hospitalists, 8 primary care physicians, 3 primary care PAs, and 1 primary care ARMP. So we've got a total of 18 MIPS eligible clinicians. But of those, 6 of those are considered either hospital-based or non-patient-facing based because they're radiologists, CRNA, hospitalists, and emergency room physicians. They are using a 2015 certified edition of an EHR, and they plan to do full year reporting. So David, I know, has pre-populated some information for us in there, and I will turn it over to him to show you what he's got.
Okay, with this particular group is where the total case volume starts coming into play. As we see, we entered in there for the quality that is, they have a total case volume of 155, which of course is ridiculous for $1.8 million. But if we increase that up to a 1, then it adjusts your quality points because you're starting to add in a readmission rate measure that we don't have info on. That's calculated after the fact and will be done by CMS, so they just get the standard minimum of a non-benchmark measure of 3 points. So it goes into it. We've gone through adding in some different measures that they're doing: breast cancer screening, pneumonia, stroke. Registry the same way, and as you see, the same calculations are occurring. If you look at the needed rate for maximum points, you'll see the direction that you need to be going. Like, it's going 87.93 to 100. So that means the higher your performance rate, the more estimated points you'll get. Now, if it was the reverse, if it said 100, like, it would say the reverse. It would 5 to 0 if you were supposed to be reducing your performance rate to get better points. There's less explanation on this one. Again, the grade out. Now, if we go through, let's just add in some additional measures on registry. And now this one, you'll see it bumped, big red word saying benchmark submission method is not listed as available in the final rule. This one, they have provided us with benchmarks for this submission method and this measure, but it is not listed within QPP or the final rule as being available. So I wouldn't guarantee anything on this one, but it is there. So it allows for, if that's the only option that you have. If we go over and try out 334 as a registry, it grades it out because no matter what you do, it wasn't in the final rule. We haven't received any benchmark for it. It's not in QPP as an option. So this one, you cannot be reporting through the registry. So this one, it doesn't matter. Its points will not be calculated. Anything else. And so we can delete. Now, each of these that we've added in, even if they're not going to your performance points, they can go towards your high priority bonus points, up to a cap of 10% of the allowable points that are on your domain cap, which is that out of 60 and out of 70 if you have the readmission rate. So we have three outcomes, so that'll be 6 points, 7 points, but since that one's not done, it can't be allowed. Then we go over to advancing care. This one we're dealing with the EHR 2015, so it adds in some additional measures. It technically just kind of splits that 2014 health information one into two. It's the sending of the summary of care electronically and requesting and accepting the summary of care. But that splits it off and there's two different rates that you can receive for those, along with giving an option for patient-generated health data. This isn't probably being used that much, but it is there to help. When you start going through, again, same rates. It's all based upon the decibel. It's a rounded off values. They have tried to do a bonus. They're doing the active in participation with public health. But if you notice, I've checked this one, which is a requirement for the bonus, and it will highlight you to that on the exit report. I'm telling you that the public agency reporting bonus cannot be obtained without the optional measure. So that flags you and say, oh, wait a second, I gotta go back and check that. I should have said yes to that. And it'll disappear and you start receiving your 5 bonus points. Again, citations into the final rule for every purpose. Everything that's being talked about is down in the calculator. Now we've gone into the improvement activities. They are doing the providing 24/7 access to MIPS clinicians is being done, but they're not taking advantage of using CERT to provide a bonus for the vaccine care information, which that would be something that they could look into doing to hopefully increase their overall score. Cost, of course, is not being done this year. It's going to be started next year, or it should be. And we can go back and look at the MIPS tab and look over it. The whole scenario with the calculation of the quality, it gets a little confusing. It's the whole problem of that you're doing estimated points out of 10, adding them together, and then doing a out of 70 with that, and then doing the percent again. So you're kind of doing the division, multiplication, then division again, which kind of seems very redundant and useless, but it's the way it works out. You can see that the standard reporting is the final score. They have maxed out their improvement activities. They have maxed out their vaccine care information at 25 points. And they're coming close to maxing out their quality. Now, as we get down to the bottom, we can start doing estimations. If you believe that 57 is a small number and that, in truth, it's not going to be just a point higher than what could be based upon using the exceptional threshold, which is technically is calculated at 125% of the performance neutral threshold that's provided to us by the HHS secretary before each reporting year. If you believe that that number is technically going to be higher and that it's going to increment quicker, then you can change it. And at the same time, it adjusts your exceptional and your minimum. Now, these are the exceptional is the point where you have maxed out your base values and you get the highest amount that you can out of it, and you start going into the exceptional bonus money. The minimum is where you have capped at the maximum negative penalty that you can reach, and no matter how much worse you get, you're not going to lose any more money. It's going to be the same amount that's taken out. But you can see that this person stays up. Let's do even more extreme. Let's start them off that it's going to be 90, 95, and 99, so that you can see how it starts working. On the exceptional, you can see that they're neutral for next year is 90, which if they don't do any improvement means that they're going to be below the neutral payment and start going into a negative adjustment of 0.05%. So they would need to at least increase their score by 1 point. And again, for the next year, they're losing money and would need to increase it by 5. Now, it will cap you, of course. But you can see the auto calculations without between how much money they would be losing each year in total over the total MIPS incentives over the next 4 years would be $39,000 after the adjustments with these high rates and things of that nature. Along with, you can go over to the graph and see it visually for the spanning. Let's not go there. Kind of need to lower it some for it to be even visual. You can see at the points in which the scale goes up and you see a kind of corner, that's the point at which you've reached your score where your additional start going into your additional bonus factor. And the cross-section shows you the ranges of percentages that you may be receiving from the top that's about 15% all the way down to 0. Now, if we go over to the exit report, you can see it actually value-based. You can see the ranges. Let me change that back. You would see for your 2019 year, the neutral threshold, the performance threshold provided to us provides you with a total adjusted factor of 10.6%, based if their assumptions of the applicable percent in the final rule is actually what's going to result in a neutral budget, result in budget neutrality, then you'll be getting 10.6%. And gives you an adjusted reimbursement of $190,000. Now, since that is not a known factor, if that their applicable percent is truly what's going to result in budget neutrality, your ranges of percentages could be anywhere from 0 to 18.6%, which results in anywhere from $0 to $335,000 for that year. So in truth, real range is anywhere within there. The believed aspect by CMS, whenever they wrote out the rule, is that you'd be getting somewhere around the $190,000. You can see different flags of the cost-out measures, the county reporting, and all that at the top also. The different pools that are provided within these tabs that allow you for sorting in case you are someone that is wanting to do the cardiology measure set. Then you could filter by that and look at the different measures you have available. Is there?
That's great, David. Thank you so much. It just shows how powerful this tool is, and that it does the thinking for us with all the calculations, and that is truly just shows the robustness of it, and it's extremely helpful. And we can't thank you enough for sharing that with us here. And I'm going to talk now, if you want to go to the resources slide. Oh, David, if you want to pass the ball back.
Yes.
I will show the resources that everyone has available to them with your organization, with our organization, and all of that. So here we are, back now again. And just so you know, those hypothetical scenarios are in this slide deck, so you can see that if you want to review that recording too. But the MIPS calculator that Great Plains QIN-QIO has developed is shared on our website here at Telligen as well, and those are listed here for your reference. And then if you would rather not use a calculator, the same tool is available in a worksheet, and that is here. There's a link at the bottom of the slide here, and that will let you use that, download that tool as well. It's the same thing. It's just in paper form, and it's also on the TelligenQPP.com website. And now Caitlin will talk about their services there at the Great Plains QIN.
Yes, for those folks that are on the line from Kansas, Nebraska, South Dakota, and North Dakota, this is our Great Plains QIN Service Center, and we have promoted this many times, but again, this is how you can reach the Service Center, and you can get a hold of support staff like myself in each state through several modalities, so certainly utilize this resource. We're available every day during business hours. And here are the state leads in each state for Kansas, Nebraska, South Dakota, and North Dakota.
We have lost sound.
Yeah.
Oh, sorry. Sorry about that. I'm talking on mute. Thank you. This is Michelle. This slide here is a slide that if you've watched CMS webinars, you've seen this slide. This is a proof that CMS really wants to make sure that there's assistance available for the quality payment program for every practice size and every state. And so if you're a small practice, like the hypothetical scenario, you have the SURS organization available to you. If you're a bigger practice with 16 or more clinicians, or in an ACO, you have the QIN-QIO available to you. Also, if you are interested in transforming your practice to work towards an advanced alternative payment module through the Transforming Clinical Practice Initiative, or TCPI, you have Practice Transformation Networks available to you. And then finally, but definitely not least, CMS has done a really good job with their portal at the QPP.cms.gov website. There are tons of resources out there, and it's quite interactive, so we encourage you to continually check out there for new resources available. And then finally, we have the slide with Sandy's contact information, my contact information. Please feel free to reach out to us with any questions, both on how you can use the calculator or the worksheet tool. And we are really, again, we can't thank David and Caitlin enough for not only letting us use this tool, but presenting here today. This has been extremely helpful. And now we're going to open it up for questions and any questions you might have here in the remaining minutes that we have.
I also put those MIPS Calculator websites available to you. Telligen has rebranded these with the permission of Great Plains, as multiple other QIOs and SURS have been given permission to rebrand, so they are on our website. But Michelle and I would be happy to walk you through your scenario. If you wanted to reach out to us, we could set up an appointment time to do that as a teleconference and help you kind of walk through to get you guys started. These are great resources to start tracking how you're doing, and also to start strategizing which measures you want to be reporting on and which method, submission method, you'd like to report on also. Do we have any questions? All right. Well, with that being said, we'll give you a few minutes back to your day. And again, thank you so much, Caitlin.
One question, have a chance?
Sure.
Just real quick, let's say you have a physician that is going to retire maybe in a couple years, reporting independently by NPI number. Would he have to do this because by 2019 he won't be getting reimbursed?
If you know for sure, if you know for sure he's retiring, then you would not, because it would not affect him in 2019. However, I will tell you, I would go ahead and at least attest to like an improvement activity or something so that he can avoid the negative payment adjustment. Because I know a lot of physicians who say I'm retiring, and 6 months later they say, you know what, I think I'll go work in the ER, or I think I'll go work in just doing the urgent clinic, or 1 day a week, or whatever, and then here they are right back in there, and then their Medicare reimbursement will be affected in 2019. Even if they're working for a different CHIN at that time, they'll pull it over if they're if there was no calculation for the 10 that they're new to. So I think the best thing to do, and I would strategize it by at least doing a test case type activity, you know, one of the performance categories, and the easiest one to do would be the improvement activity most likely. And you can do that through our attestation portal once that's available in January, and it isn't going to cost you any additional money, but it may just save you money in the long run for his reimbursement.
And if they already have an EHR and have started doing at least the base requirements, already have it in effect, whether they're doing well in it, but have at least started that whole scenario to get a one in the denominator, in the numerator, then they should report that too, because at that point they could actually start receiving a positive adjustment, because until you score in two categories, if you only work in one category, you'll never get above the neutral threshold no matter how much you do in it. You have to at least report it two to start receiving any positive adjustment.
Okay, thanks.
Great point, David.
Yes, thanks. Thing that's been missed by a lot of people.
Yeah.
All right. Well, thank you very, very much. Again, we appreciate Caitlin and David, and we also appreciate you guys attending. As Michelle said, you will be receiving a survey within the next couple of days. It's very simple. It'll take you less than 10 minutes, but it is very valuable to us. It's very valuable in our contract so that CMS knows we're providing you guys assistance, but it also is valuable to us so that we know what it is we can be doing to make these more worthwhile for you. Thank you very much.
Thank you. Have a great afternoon, everybody.